On-the-scene coverage of ACC.14 is supported by Janssen Pharmaceuticals, Incorporated.
Hello, I'm Tony DeMaria here for On the Scene, and I'm talking to Dr. Ilan Goldenberger, who's the Chief of Cardiology at Sheba Medical Center in Israel and the principal investigator of an important trial presented here dealing with Madit-Crt in patients with mild congestive heart failure. Dr. Goldenberg, tell us about the study.
Madit-Crt was actually the first clinical trial to show that early intervention with cardiac resuscitation therapy in mild heart failure patients, heart failure functional class 1 or 2, was associated with significant reduction in the risk of heart failure events in this population. We evaluated the long-term outcome of this population over more than 7 years of follow-up, because during the initial period, which was only 2.4 years, we identified a reduction in the risk of heart failure event, but possibly due to the relatively short follow-up time of the trial, there was no survival benefit. Now, over 7 years of follow-up, we showed that in patients who had LBBB, left bundle branch block, there was a significant and pronounced survival benefit, more than 40% reduction in the risk of death. With an NNT of 9 patients needed to treat to save one life with cardiac resuscitation therapy. In contrast, among patients without LBBB, there was no benefit for cardiac resuscitation therapy and even a trend to an increase in the risk of mortality.
Now, why do you think that patients with left bundle branch block and without it, who have an equivalent degree of QRS prolongation, differ so much?
Yes, correct. This is an interesting question because the findings were actually indeed regardless of QRS duration. So patients with QRS greater than 130 milliseconds, if they have LBBB, they derive a significant survival benefit regardless of QRS. And if they have had no LBBB, there was no benefit or even harm regardless of QRS. This may be possibly due to the more heterogeneous pattern of activation in non-LBBB patients. We have actually shown in prior studies that CRT even increases the risk of arrhythmic events in this population.
So one might think, well, the patients get a reduction of events short-term, even in the group without LBBB, but if they're going to incur a mortality deficit in the long run, you probably wouldn't do it. So what's your practice now? When do you use CRT, ICD, and when do you use ICD alone?
So going on the results of this study, we would recommend as a class 1 recommendation for patients who have mild heart failure patients, LBBB, those patients should get CRTD devices, cardiac resuscitation therapy with a defibrillator. Those without LBBB, RBBB or IVCD, they should all get defibrillators if they have left ventricular dysfunction, but no cardiac resuscitation therapy according to our present results.
An important take-home message. Thanks a million for being with us. For On the Scene, I'm Tony DeMaria.